Glad to have Dr. Arnold here with us. We've worked together for, probably 1 to 2 years or so with different clients, probably a lot before that even.
Right.
But really that we've really, worked together closely at that level. This is the doctor I go to, my functional medicine doctor. Why don't you kind of give a little bit about your background?
Sure. So I started CLAVA Health, our functional medicine practice, about 4 years ago now. Had been previously in the hospital system working within critical care emergency medicine and seeing that system limit on what we can offer individuals and stuff. And so that prompted my education and furthering of my own kind of inquiry training as well as in the practice. And so we are now a very kind of excited practice where we're focusing on really looking to root causes for helping individuals reverse conditions, not just accept them, not just manage them, but to try to find why they're happening and reverse it. And I think that's where you and I started working together, was the realization that a lot of this stuff, the downstream, if you will, or the ultimate organ that we care the most about, our brain, is so sensitive to these markers and so important in this factor. So our practice really does try to get to those underlying causes, try to figure out ways, ideally without too much intervention therapeutically in terms of pharmacy and medications and requiring a prescription drug the rest of your life. That's the goal.
Right, exactly. I love it. And I mean, so many patients, when they ask me, who they should go to or something, a lot of times I've referred them, to you. And what I love is when they come back and they say, he spent so much time with me.
Yeah.
Right? Spent time with me. Took a lot of different tests, but took the time to put all those together, look at each person as a whole person, not just as a 10-minute kind of check off my list, get through all my patients today.
Right.
I think that's the biggest difference between what you do and what kind of the medical, side is out there right now. It's just kind of getting through the insurance side real quick versus really spending time with people and getting to know what the root cause is. Because it does take time.
It does.
It takes a lot of investigation. Everybody's different.
Yeah, and the individuality of that is so important, because you realize that the factors that someone struggles with are not going to always check the box on paper of like, oh, just do this one thing. And maybe their lifestyle or their stressors or their job prevents a lot of the solutions that we would come up with. So we have to personalize that response to what fits in their life at that time. So we try to meet them where they are, help them through that, not be like, oh, here's the ideal sleep schedule if they're a new mom. we can't force that on that situation. We have to accept that and do our best to find those moments and stuff. So
absolutely.
But I think that's where medicine needs to come back to, which is back to the personalized relationship where the individual feels connected to their team of caretakers, right? That they're all aware of this individual from all the different layers of it and stuff. So that's where we see the most success around it.
That's right. And that is exactly why we started working together too, because from a neuroscience perspective, we can scan the brain and we can see where it is today. But what I always tell people is that I can't tell when this occurred or how it got there.
Right.
And I always tell people, typically, outside of maybe of a concussion or something like that, it's not one factor. It's many factors, metabolic factors, sleep factors, stress factors, all the, even nutritional factors, which influence the metabolic system and everything, how the brain works. So many things, exercise, lifestyle, all these things. And that's where we can see that. But, I never want, my practice to be something where we do everything, where we don't. We are a piece of the puzzle. We can scan the brain with an EEG, which is like a resting EKG, right? Which we can, gain a lot of information from there. But, my goal is always to say, hey, based on this EEG, you need to go look at peptides. You need to go look at this nutrition. You need to look at TMS. You need to look at neurofeedback. The neurofeedback that we do is one tool out of a lot of tools that needs to be addressed. And that's where I've loved working with you on this, because you address a lot of those tools too. Why don't you tell us a little bit about some of the brain tools that you're using now too?
Yeah, and I think it starts with what you mentioned, which is a lot of these foundational things that can cause those syndromes. And so it's the root cause assessment is our first intake, because, as one of my adages I often say is, if you do everything perfect from 7 a.m. to 10 p.m., but you don't sleep, it doesn't matter. The perfect day, the perfect peptide, the perfect therapy doesn't matter. It's not gonna
so
matter.
Foundational.
So there are foundational things, and we look at them and define them. from a nutritional standpoint, from a metabolic standpoint. We look at root cause assessments. A lot of the stuff that has been out there now for over a decade from Dale Bredeson's work and his recent study that will come out this month, probably very exciting news in the Alzheimer's world and cognitive decline reversal, which they can show, but really gets back to individualizing the therapy around what that one person needs to be needs to be augmented for. So that's the first step. Is just like, what are you dealing with? What is your thyroid? Is your hormones? Is your sleep? Where are those things optimized? Once that's assessed and we've addressed those issues, part of that intake is also how is the brain functioning. And so to your point, looking at mapping and saying, what is this footprint of a previous experience, whether it's been several insults over time or one big insult like a concussion or many concussions as we've heard with CTE and other
small little repetitive hits.
Correct. Their brains are not meant to handle really well. And plus we don't have a really robust system around how to recover that brain and how to monitor its recovery. So the ability to look at that signal and say, okay, there's something there. We've started working with a new technology called ViewMind, which was really exciting because then it's kind of like the stress test for the brain, and it puts the brain through in a 15-minute exam using eye tracking software on a VR headset, multiple exercises that we then quantify how that individual performs, and these are going to be through executive function of the brain, working memory, spatial processing, long-term memory, and attention. So these aspects, hitting these domains of cognitive function, give us this very earlier marker, as opposed to waiting for many of the times these cognitive assessments are looking for signs of stroke or injury or damage, which they're important tests, but when that you're like not firing on all cylinders and you're just not having a good day then because you slept 3 hours, we know what that feels like. If I cognitively tested you on a memory test, you wouldn't perform as well if you had an 8-hour sleep. We wouldn't expect that to impair your stroke evaluation. So this gives us this earlier upstream marker that is much more sensitive to detect these conditions. And then the beauty is it can be repeated. We can do this, and it's standardized and normalized, so they can be done again, in a month or a quarter after we do some intervention and see what kind of impact the treatment we have done has been. And I think you've talked about with your patients on omega-3 optimization, nutritional stuff, on better sleep. Those little interventions alone could move the needle a little bit there, right? And that's
even looking at genetic tests too.
Oh yes.
Understanding how you're processing or breaking down those vitamins. You can be taking all the right vitamins, and your body's not even methylating it, and breaking it down. So,
and the methylation is one big factor. I think what's been really exciting in the genetic space that we are expanding our program to reflect is that even we talk about the ApoE gene, right? One of the genes very connected to cognitive decline risk, but that by itself does not tell the story. You need to know the other augmenting genes around it. And I think it's almost to the point where we're realizing it's unfair to tell an individual just their ApoE status without knowing the bigger picture. So and that's just one aspect of it, but there's also how our body processes inflammation and oxidative stress and burden. And so where you can individualize the support around that individual so that they know, I need this, not my partner. Who doesn't need this one thing, but I do for my genetic burden.
Exactly. Yeah. Really taking it from an individual side. So, I wanted to kind of talk about from the assessment side, again, what we do with a resting state EEG, it's looking at the brain. It's kind of like looking at an EKG of the heart, right? And, if at rest your brain's staying up under stress and not coming down, it'd be like at rest having too high of a heart rate, or at rest, it's not functioning even enough. That'd be like having way too low of a heart rate at a resting state, which obviously those things are going to impede function, right? And there's no reason at that point to do a bunch of performance tests when you're not even at a baseline, right? Then, but you can be at a good baseline at rest, just like I could have I tell people all the time, probably my resting heart rate and LeBron James' resting heart rate are probably going to be fairly similar at rest, right? But you put us both on a stress test, on a treadmill, they're going to be very, very different, right? And, and that's where some people are like, well, my brain map, my EEG brain map was normal, but I still feel like when I'm really pushing hard here and stuff and doing some cognitive things, it's not quite optimal or maybe it's failing or something at a certain point or something. And this is where like the view mind can really start to show us, under stress, what the brain's doing.
Right. And I think this is where I think functional medicine has pushed this discussion, and just this longevity-based practices that we kind of aspire to has helped us rethink our approach to these metrics to say, why are we waiting for these things to be, only do this test when there's symptoms? Because you can imagine if this was a test that sadly, is not covered by insurance yet, and hopefully in the future it will be, and they would approve it based on certain conditions.
Yep.
And that's not how we approach these conditions.
You don't want to get to that condition.
No.
You want to stop it before.
Correct. And it's also this belief that we can move the needle on those conditions by addressing the abnormality up front. Yeah. So that stress test is no different than what everyone is more comfortable with and familiar with, which is a cardiac stress test or a heart stress test, where they, your EKG of your heart could be perfect, but when we put you on a treadmill, it shows strain. Right. That was not there before. Well, that's a dynamic component that is changeable, that is we're under stress, that could be a big problem in the future. And so similar to how we use a glucose monitor in the practice. Mm-hmm. This is one of the factors for me that is such a telling component when they look at cognitive decline and how the type of cognitive decline can be variable, and it can be more predominantly impaired by someone who has a blood sugar regulation issue.
Absolutely.
Compared to a lower hormone state, right? And those two factors can be very different. And Dr. Bredesen talks about these in his the hot and the cold brain and the different scenarios. But it's an example of just like we can't predict it without measuring it, and you can't predict those systems. So the brain, we can the brain does a good job, I always say, of protecting itself against acknowledging the problems. Yes. So sometimes
covering up the symptoms.
Yes, covering up the symptoms. So it would be really good. No, I'm really good at this memory component, but I can't name a stranger's face to save my life, or someone I haven't seen in a while. And I think that because it can do that, it doesn't want your conscious awareness to hone in on those abnormalities, because it wants to feel like we're okay. And so I think that when we can uncover that, and what I also like about this is because it kind of gamifies it by following a dot and following some instructions on a screen, it lowers the anxiety of the test. Right. Some people that have gone through these extended cognitive tests, some of them can take several hours.
Yes.
You're very aware when you're missing a question.
Yeah. And you get frustrated.
You get frustrated. Yeah. And now you're like, what does that mean?
Right.
And they're not telling you, they're not giving you feedback to what it means.
Right.
They're just like, let's move on.
Yeah.
And you're like, I know I did badly on that. Does that mean I have dementia? Does that mean I have Alzheimer's? Right. And so that anxiety builds. And just like measuring someone's blood pressure, as their anxiety builds, it's going to go up. You're going to do worse. So this is something that is almost like playing a video game. It's like playing this little, thing that removes them from, I've seen the anxious component reaction to it, and lets them just perform. Right. And perform like under strain. Like some of these tests they're not easy, they're not comfortable. But
you're not meant to get it perfect.
Correct.
Right? I mean, it's age normed and stuff with this.
It's age and education normed, in fact. So they look at because the brain develops differently after different stages of education. Right. If you're collegiate or graduate school, there's different than it's not about IQ. Right. It's about the process of the brain went through. Exactly. Right. So it's like it normalizes it across those fields. And then the best thing, and this is like what I think you've aspired this with me and shown me, that brain mapping is important, but serial mapping is more important, right? Yes. Knowing you, the individual, is great one point in time, but to make a bell curve of normal and put you somewhere in that middle. Yeah. Well, what if you're always here and suddenly you're here and still within the normal range? Right. Well, that is a change of you to you, but not a change of you in the norm spectrum. So. And everyone's always heard, I always use the example of a heart rate, as you mentioned, heart rate. It's 60 to 100 is normal. Right. 60 to 100. So 99 is a normal heart rate. Yeah. For no one, actually. Right. It's not.
I was going to talk about that, but, because like you said, there's these optimal levels, right? Yes. And then even more important than the optimal level is your normal level to see change when that starts changing. But if you go to the typical medical system, their ranges, even on a blood test, right,
it's-
are so far like, oh, you're in the normal. But you're way down. I mean, that normal is huge.
It's almost useless.
Yeah, it's basically, if you're outside the normal, you're so far gone already that it takes a lot to try and recover. It's broken by that point, right? And I think it's the same thing with the brain, that when we can see when things are starting to shift, this whole idea of longevity is huge, because longevity is, I want to stay in this optimal range, right? Mm-hmm. I don't want to start slipping down and then fail here. If I can course correct in this optimal range, when I start barely going away, I can do a lot from it, a lot with it, and keep measuring on through life and stuff too. It's, with AARP, when we did a lot of studies on aging and everything, we did a lot of cognitive testing, and we showed that from 40 to 80, that the normal, now I'm not talking awful, just the normal peers actually drop about 40% in most cognitive, executive function, memory, and a few different types of things. However, there was a group that stayed less than 10% drop. Okay, so 40% is the average, and a lot of people say, well, I'm doing better than the average. The average is doing nothing to prolong their brain, right? That's with nothing going on at all. They're dropping. But when you do some things to it, a 10% drop from 40 to 80, that's what I'm shooting for.
Absolutely.
Right?
Yeah, and that's, it's interesting that's those kind of small, kind of outliers in the positive are really interesting groups. There's a group that they study out of Northwestern called the super agers.
Oh yeah.
And they're like, why do these people at this same age have zero cognitive decline?
Right.
And what's common about their brain characteristics and their functional status and stuff. And so they're quantifying. This is an ongoing kind of a epidemiologic study, but it's super fascinating to see that, because it shows you that that's possible.
Yeah.
Like, what is it that, while we're accepting this as common, doesn't make it normal.
Right.
And I think this, when we talk about this with bone density, we're like, yes, there's a bone density curve that does this.
Right.
Does that have to be you though?
Right.
And how can we kind of prevent that and try to address that? But I think, and the brain in particular, and I think one thing when you talked about these modalities of how we are assessing them, there's so many angles to look at the brain, and I've had people ask me, like, which one do we need to use? And I'm like, to be frank, we need all of them, because it's kind of, they're asking different questions of the brain. So when I have someone, and I'm working with, so if there's cardiologists out there that want to work with us on this, I've actually had some pushback on this, but to change the approach where we do a stress test for non-symptomatic patients, like, doesn't get covered by insurance, because the insurance covers reactive medical care. They don't cover what we do, because they don't see the value in that. And so the ability to do a proactive cognitive stress test, cardiac stress test, physical stress test. We talk about with neuro things. I have people all the time in my office will just be like, really quick, stand up on one foot and, balance. Right. And that's its own test. And I'm like, now close your eyes. Right. And all of a sudden you realize, and you can do this to a 10-year-old, much less an 80-year-old, and watch how much the brain needs the visual access and these components and that, but how it can be trained. Yeah. And when you realize, and this is the exciting part of brain science and brain health to me, this is kind of why we have really pivoted. And I think, seeing the work that when you and I started, when I started seeing the feedback from the scans that, and a lot of the tracings on these, injured, inflamed or damaged brains, but also how they can improve. Yeah. And to me, that plasticity component, or the healability of this brain, which we've been told, we're taught in school, it's a one-time thing, and after 25 we're done, right? And that's just, it's so it is so off mark at this point, and that's what's so encouraging for us, is that people they can feel the hope now about, I can take charge of this, and I can feel better by taking charge of all the other aspects that I didn't think were a big deal, but cumulatively they add up to these big problems and stuff. So
I think in the future here, once so many people start embracing all these things, I believe we have the technology, the assessments, the interventions now, and they're going to get better even with time, to get the average person to living in a good health span, healthy, all the way up to 100 plus, if we do everything right. The problem is it takes time, it takes money. Insurance doesn't pay for it, right? Stuff too. And, when people ask, why, if this is working so well, why wouldn't insurance pay for it, right? It's going to save them money. And I always give them the analogy, it's not an analogy, it's just, straight fact, that insurance companies are interested in profit for this quarter. Yeah. Right? So if I am already covering all the problems and spending hundreds, if not billions, hundreds of millions, if not billions of dollars on that, and now I add preventative, that's going to help me 10, 20 years from now save money, that CEO will not be around 10, 20 years from now. Mm-hmm. They're going to actually be fired if they start spending too much money now because their next quarter profits go down. Right. So if you had an insurance company that was a family-owned company that was just worried about the next 30 to 40 years, believe me, they'd be paying for all this because they would be saving so much money in the future. But when you have to cover all this now and add the preventative on top of that, the company's going to go, I wouldn't say broke, but they're going to lose a lot of their profits, right? Which is what it's such a short-term thing that they're looking at.
Well, and I think, and on that note, I mean, I this is where a lot of our just people that are not in this space professionally don't see this dirty underbelly. Right. But the average American is with their insurance company 6 years. So I don't even have, if I'm the insurer, I don't have an incentive to keep you because you're going to be moving your job and or spouse to a new. That's a great point too. And so now they're like, I'm going to the quarterly performance because they're a public company and they have to report that. But then also they're like, why do I care how your DEXA scan is going to be and all your brain scan is going to be? And so I'm with you. I think it's a sad reality that people have to choose to invest in themselves and stuff. And it's funny, I know these are already coined terms. I don't like. I looked up to see if people already bought the trademark, but the brain span or the mind span compared to health span or body span, because it's realizing it's the functional status. Exactly. It's keeping our brains functional, not just existing. Yeah. So if we all what we experience every day is our physical body and our cognitive ability. Mm-hmm. That's all we really know. Everything else we're doing is to keep those things going. Right. But that's what we ultimately experience life in. And so I think a lot of our awareness now in the health and wellness space is that our brain function is we almost are almost hyper attuned to it because we're realizing I know what this means if this happens. If I forgot my keys, is that a symptom or is that just a factor of me being overstimulated or over consuming, not paying attention to life and stuff. So this is but those are important questions because we've seen early onset cognitive decline in 40, 50-year-olds. Yeah. And why is that? Well, there's a genetic component, but there's an environmental one. And so those things couple together. And so we don't just want to be it's because of genes and you have no. Right. And they're given no hope. They talk to neurologists, sadly, and neurologists I have nothing to offer you unless it's a drug once you have symptoms that dictate this certain level, and the drugs are ineffective.
And there's so many things now with genetics. I mean, with epigenetics, there's so many things where we know the mechanism at which this gene causes the problem. And once you understand the mechanism, you can actually alter a lot of that, right? If you have a gene that stops you from methylating vitamin B or something, you can take methylfolate or other forms of it that get through. With ApoE4, stops a lot of the omega-3s from crossing and getting embedded in the blood-brain barrier. You can go up to a higher amount and get through. There's a lot of things you can do. One thing, before we end this too, is I'd like you to talk a little bit about the peptide therapies and stuff you do, because I know it's kind of a big thing that's really coming in right now. And there's just so much validating this. I mean, I've talked to so many people that have had so many inflammatory issues, this issue, metabolic issues, even after injury, right? And then getting the right peptides, healing so much faster and stuff. Right. So maybe talk a little bit about that.
Yeah, this is where we move from the diagnostic of a problem, and then what are we doing about that? And that's where a lot of times people feel lost, is that they get this extensive neurologic evaluation. They're like, yeah, bad news. What do I do about it? Nothing, or here's a drug that doesn't work, right? And so the advent of peptide therapies has blown up in this space, and we've seen a lot of opportunity and agents that have a lot of promise there. What's really exciting is that I was always struggling with how to implement them and what sort of arc of treatment I would tell someone to expect, because if I start, we know neurologic processes you can't just do 2 weeks of an antibiotic and get rid of an infection. We have to we have to rewire and re-empower the system, but how long does that take? And so this is where, for me, it coupled nicely with the diagnostic sensitive picture like a view mind, then to couple with peptides. So there are certain peptides that we know we can augment an individual and see if that improves their brain, in either the functional status on some of these markers that they were impaired on, or even some of their own awareness, what we call subjective cognitive issues that they're feeling it, and they're in. It could be moods, it can be even sleep issues. And so there's peptides. Everyone sort of BDNF, a very popular molecule, BDNF, brain-derived neurotropic factor, which is, it's self-created in our body. When we exercise, we increase our BDNF levels, right? When we have good sleep, we can increase.
And all the way into your 90s.
Correct. I mean, it is a fungible, regularly created thing.
I've heard it's called the miracle grow on the brain.
Correct. Right? It's this beautiful agent that interestingly is it by itself, needs all the other aspects. You will want inflammation down. You want nutrients like omega-3 levels adequate, phosphatidylserine, choline, all these building blocks, right? But imagine someone is missing that or having early issues or a previous injury, and they're young, but they played football and they had some, some issues that we're trying to address. We can augment that. And now we want to know, well, how long should we augment it? Is it working? And then we can just do these earlier assessments. Right. So you coupling that, and then imagine that with a repeat map, a repeat view line, and we see how someone's moving. So those are really exciting. I think there's other classifications, like the huperzine is another peptide that is really interesting on some of those connections in the brain. Yeah. We're seeing C-Link as another one, which is a peptide that really works on cognitive, what people are experiencing on almost anxiolytics, like helping anxiety break down in a natural way. But the goal of these peptides and all of them is just to help reset a pathway, but not be a permanent destination. So this is what's different from peptide therapy compared to pharmaceutical generally industry, where it's like, here's your blood pressure medicine for the rest of your life. Right. And it's very just kind of like, another one. And so the idea, and this is, again, we are in the infancy of this understanding, because as these peptides come on board, there's cloth though got produced by a peptide company. I have no idea if that's going to be get cross the blood-brain barrier, be effective, and show efficacy. However, it's exciting because we can now test individuals, watch how it interacts with them.
The assessment part is huge.
It is, and it's also, but a different mentality, which is like, couple that assessment, then with they're working on things in the brain to adjust that component that was missing, that was suboptimal. So and that's where their unique kind of reporting will allow us to guide an individual and say, hey, your executive function was the issue here, or your working memory was the problem. Let's work on those factors when you do the therapy, when you do this as your little, it's like going to the physical therapist and then your right shoulder is off. They give you exercises for that shoulder. And so it's very, very specific. But the peptides around that space have been exciting because we've seen, the ability of them to move that, that conversation to one that is brain specific, as opposed to like whole body, just help the whole body out, versus like medicine works really with the brain. And one of those in particular is not even a peptide per se, is more of a molecule, the NAD molecule, right? Which a lot of research out there, a lot of discussion around this. People have heard this in extensive, I think, iterations where they talked about the precursors of it, how much the oral get to the actual, the NR or the NMN, how much does it get converted to NAD? And these are aspects that get complicated, get very, mechanistic in the system. But I bring it up because recently we've been working with nasal application of nasal spray NAD. So now this crosses very quickly in the nasal mucosa into the circulation of the blood-brain barrier, and you can actually feel this molecule, versus when I've worked personally and in my patients with the oral versions, there wasn't so much of an awareness of taking them. Right. So now it's like, well, what if we coupled this with a peptide for healing, and then coupled that with an exercise that was doing this, and some of these non-invasive activities, like some of the different tracking activities that an individual can work to get the brain reconnected, right? I mean, those peptides offer a really exciting next stage where a lot of questions will be opened up, and we have to recognize that. We don't walk in like, everything's perfect. They're all going to be this wonder drug. But it's going to be like finding that unique fingerprint of an individual's risk. here's what your pattern is. This is a protocol that's unique to you.
Right. And sometimes, I mean, what I've seen too is these things like peptides and NAD and stuff, it's sometimes a push to get back to homeostasis in the body, right? Because if it gets so far out, it's really hard to get there sometimes, even with right lifestyle, where this can push it back, and then continuing the right lifestyle and stuff can maintain it. Versus, like you said, when you're so far out, just take a medication that you're not changing anything. It's just trying to help, but causing a lot of other problems at the same time.
Right.
And stopping your body's processes from having to even work itself, because the medication's taking care of some of the symptoms, right? Just kind of masking it.
I think that actually brings us back to when you and I was first working together, and a lot of our patients' children had seen you to try to get them off of ADHD medicines and what's some underlying things. And so again, the American mindset, sadly, is one that is really driven towards a pharmaceutical model that says this is your destination drug. And that's it's just when we can reconfigure that and say, let's get back to balance, homeostasis, rebalancing that system, and allowing for it to reset and then get off of that, that peptide. I mean, the GLP-1 class recently showed a reduction in dementia. Like, what an amazing, unexpected finding. Now, is it the magic drug's effect on dementia? Well, no, it's affecting the underlying cause of the sugar on the
blood sugar, absolutely. Which we've known as dementia's been called, type 3 diabetes,
exactly.
Because of that,
So I think that it speaks to, and I like how you said that with the home, back to homeostasis, where we really preach this on the purpose of this is to rebalance, is to heal, is to be, is to, like, whether it's a peptide, a stem cell, some intervention that you do, where the goal is to reset that norm, and then have an operating space that is higher than you were at for the last who knows how many years. And so I think that's where it's exciting. Technology blended it, but it's this. There's this concept I love, a word called theragnostics, and I think they made up this word a couple of years ago, but it was whereas a therapy is matched to a diagnostic, and I think this is where we are in this space now, where we keep reiterating, coming back to, okay, diagnose the brain issue, do a therapy, come back to reassess, and we go, and that iteration allows there to be this nice ability to personalize that and coupling that, because we just talked about several aspects, and I think we could touch on one more that we're bringing on as well, that helps an individual figure out, is this therapy that we tried working for me? And I think that's one of the things that people get frustrated with the medical system very commonly, which is they get told this is, whether it's the practitioner is independent, it's just more like, this is what you need, as opposed to like a very humble attitude of like, well, we're going to try this and we're going to see how this works for you, because I can only predict how you respond.
Exactly. And measure. Just because it worked for someone else doesn't mean it's going to work for you. And I think that's part of the problem that this industry kind of gets in, longevity and stuff too, is that when it's not personalized, well, then it's a million things. You have to take all these vitamins. You have to do all these therapies. You have to do all these tests. You have to do everything. And the problem is people get overwhelmed. And I always tell people, vitamin D will work really well for people that have a deficiency in vitamin D. If you don't have a deficiency, it's not going to cure the same thing it cured someone else who had a deficiency. So to tell everybody, anxiety goes away with vitamin D because it worked with this person. Their anxiety was probably due to a deficiency of vitamin D. So yes, but without personalizing and getting it to the few things that will most likely target your problem based on your physiology, and then retesting to make sure it's making those changes. Because if it's not, we can't always get that target perfect at first. We can narrow it down, but then to see, is that really the problem? And sometimes it lowers it just a little bit. And then you need other things. I mean, I always tell people with high anxiety, with neurofeedback, we can lower that down to where it's manageable. However, you still have 20, 30 years of the habit of anxiety and looking at something and your brain goes to anxiety. This is where therapy can help. This is where EMDR can help. This is where heart rate variability, biofeedback, things like that can help. Getting the right nutrition stuff. But The problem is when the anxiety is so heightened, those things can't even help because you can't even get to that point, right? And so sometimes it's layers too. And that's where retesting says, okay, that layer worked to this much. Now let's move to the next layer and the next layer and keep testing as we get down. Talk a little bit, because we're getting to the end here, a little bit about the exomind and stuff.
So on that note, it's interesting because this technology has been applied into that population of anxiety. But so there's an established technology that's been around for over 50 years, and that's called transcranial magnetic stimulation, TMS. Just means across the brain, magnets that stimulate brain activity, and this has been initially very cumbersome of a technology, and with the new companies that we have been working with, BTL has created something called the ExoMind, which is a device that sits on the brain on the back of your head. That's a 20-minute session, and that session starts this process of turning on a brain responsive reaction that stimulates something called synaptogenesis, or connections between our neurons. So it's not building new neurons per se, although there is some evidence in some animal models.
I was telling people it's kind of like jump starting a battery that died, right? And getting it back going. And once it's going, it can maintain it.
And this is where the technology exists, and just for full disclosure, it's FDA fully approved in this country for the treatment of major depressive disorder. So non-pharmaceutical based intervention that's not meant for forever. It's an intense session for the MDD for depression, but essentially here's something that has this promise that is not a drug. Like, why isn't that not front page news?
Exactly.
Because there's a reason why. There's a reason why. But the exciting thing about this is that technology is being investigated right now at UCLA for autism. It's being studied in cognitive decline. It has Health Canada has approved it for anxiety as well. So people that have anxiety, we have a case from a colleague of mine. He treated a lady who was treating her general anxiety, but who had an absolute fear of flying. And he tells this great story how she went through 6 treatments and got on a plane for a family emergency, but found herself on the plane and be like, wait a minute, why am I not having a panic attack right now?
Isn't that amazing?
Because she was focused on the event, but not realizing that she couldn't even do this thing anymore. So, but even there, like, the excitement thing that I'm really looking at is applying to many of those populations, but really just the way that we look at wellness in the brain and cognitive decline, which people think, oh, I'm just getting old, right? We don't accept that. And we use this modality to say, let's couple this now, again, with the therapies, with the diagnostic that is, okay, they were abnormal over here. And what's interesting is that where they've shown the strongest durability or stickiness of a response was when whatever you were targeting in terms of an impairment of function was intervened on right after the treatment. So let's say like memory, long-term memory was an issue. You would do the therapy and then work on a memory chore right afterwards. And so but let's say balance was an issue after a stroke, and there's been evidence of stroke recovery after these things. So now you do the treatment, then you go do the balance movements then. Now you're encouraging the brain to make this connection and embolden that. And so now there's this. I mean, they've approved its utility, its effect as little as 4 treatments. We recommend 6 at a minimum to see, but you start to see like, wow, like I can feel that difference. And so here's the, and just to, to kind of put it out there, here's the stuff we have no idea, to be frank, but we're really excited to kind of go in this space of like, how about coupling this with other modalities where we're hitting root causes, like we talked about, we're augmenting with maybe a peptide. You're coupling that with, a specific therapy around that person's diagnostic uniqueness. And now it's like, it is as personalized as it can get for brain health. And so all of a sudden it's like a very different picture than, oh, here, try this little device out or try this treatment out. And as you said, the noise of signal, of like potential treatments, people just get lost. And they're like, do I have to do this the rest of my life, or how many of these do I have to do? It's like, we need to see what that individual needs. And there are times of individuals where we've said, you're not ready for this therapy. To your point, when the baseline is so abnormal, it's just going to be problematic. And it's not the time to heal. So you don't start rebuilding a house that's on fire. Put out the fire, you restart, and then you build.
I always tell my wife, because she's so into health and everything, and she's sitting there saying, "Oh, that person, I can't believe they're not eating organic and stuff." So they're 100 pounds overweight, babe.
Yeah.
That organic does not matter to them. Okay, non-GMO, that's not where their problem is, right? They need to get the weight down, and then those things can help optimize. But gain that baseline to the right state. It's just thinking about one thing you just said about after the TMS side, and then training it. Be really interesting. We had to think about combining some TMS right before neurofeedback, because neurofeedback, we can target that area to start working and stuff too, right? But sometimes there's not enough electricity in there to actually do it. That'd be like having a really weak muscle and going to try and exercise it. Where if you can pump that up and get that nice and strong and get the electricity going and then use it, the combination could be
that's powerful. And I think that's where, it's kind of like telling someone, okay, do this thing when you get home, and they're like, oh, okay, I'll think about that, versus a neurofeedback exercise is very directed, and the feedback is really quick, so they know when they're doing it right and wrong, and they need to augment it. I mean, and I think this is how I like it, because it gives individuals this ability to feel comfortable with like empowerment and be like, okay, I can work on this. Just like when you go to the physical therapist and they give you exercises, it's not meant to exercise the 3 times a week you go to physical therapy. It's to teach you what to do the other 6 days when you have someone, you're not with them, right? So to me, that's an exciting ability to say, you and I, will also figure out ways to push individuals to personalize their treatments around it. But then individuals can also find ways to figure out what are they in charge of that we can actually, that they can do.
Which is so important. They got to take agency in it.
Absolutely.
Absolutely. Well, I think we went pretty long there. It was perfect. Great information. Great to have you here.
Thanks very much.
And love working with you.
Absolutely.
Yeah. Perfect.